Audrey, what are the devices available to take care of the patients?
So thank you for inviting me. I mean to talk about the device available for oxygen supplementation. So first we have standard oxygen. Standard oxygen, the first step is nasal cannula, as you can see in the picture, with a flow up to 6 liters per minute. Then you have a facial mask, and you can have a flow up to 10 liters per minute. Then a venturi mask with a valve allowing titration of FiO2 received, and so the flow is set from 3 to 15 liters per minute. And then at the end, the non-rebreathing face mask with a higher flow, at least 10 liters per minute. The step after is high flow nasal oxygen. High flow nasal oxygen allows humidification of high flow of oxygen with a set FiO2, which varies from 21 to 100%. The flow is up to 100 liters per minute, and it's usually 50 or 60 liters per minute. The step after is continuous positive airway pressure. There is two main methods. The first one is the CPAP Bousignac, which allows a PEEP from 3 to 15 centimeters of water, depending on the flow that you set. And then you can also apply a non-invasive ventilation interface and set a PEEP, FiO2, without any pressure support to provide only continuous positive airway pressure. If you set also a pressure support, then you have non-invasive ventilation. So the PEEP is set like a 5 you can see on the screen, a pressure support of 10, and then a FiO2. Another type of interface is the helmet mask, which also allows non-invasive ventilation. The helmet mask is sometimes more comfortable and allow to vary the interface applied and vary between classic facial mask, total face mask, and also helmet face mask. Finally, we cannot forget the intubation, and never delay intubation when needed in acute respiratory failure. As said Professor Jabert, is it time to perform intubation? The humidification devices vary according if you want to apply oxygen only or if you want to apply non-invasive ventilation or invasive ventilation. So for oxygen only, two main types of humidification: passive humidifier, like you can see on the picture, and heated humidifier. The heated humidifier would be better than the passive humidifier, allowing a better comfort. In case of ventilation, non-invasive or invasive, two main types of humidification devices: heat and moisture exchanger, here, and heated humidifier. So to conclude, what are the main devices of post-operative oxygenation? So at the left of the screen, you can see the lower oxygenation with nasal cannula, and at the right on the streak, the higher oxygenation, which is provided by the intubation device. Here, it is mainly oxygenation, so you can increase the PaO2. And here, with non-invasive ventilation or invasive ventilation after an intubation procedure, you can provide oxygenation and also ventilation, like explained Professor Jabert, providing also ventilation to decrease PCO2. So thank you, and I'm available for questions.
So thank you, Audrey. In the same way, I think we'll discuss all together at the end. Maybe just a short question. Looking to your slides, I feel that there are two different ways. The first is the Italian way, it's the helmet and one level of pressure. And I think in France, we use more face mask and 2 levels of pressure. What do you think about the interest to use 1 level of pressure? Maybe we use too much pressure support and not enough CPAP in France. Can you discuss with us this point?
Yes. I don't know. I don't have much experience with helmet like Italian because I'm French. But I think the two methods are complementary, and we cannot oppose the two methods. We have recently one patient very particular who had NIV during quite a long period and who improved and finally was cured without needing invasive mechanical ventilation. And we succeed varying the interfaces, sometimes facial mask, and when the patient was annoyed by facial mask, helmet, face mask. Okay. So maybe it's complementary.
We have an Italian expert, so Andrea, maybe just a word. In daily practice, do you use 1 or 2 levels of pressure for prophylactic use after abdominal surgery, for example?
Thank you for the question. Regarding the use, it depends on the patient, of course. But what can I say about the 1 level of pressure? This is very easy to use. It's very easy for the physician. It's very easy for the patient. You don't have to care about asynchronous or so much about setting. It is something that can be used for a longer period of time. So it's very simple, and the learning curve for the physician is not so stiff. So it's something that you know how to apply very easy. But maybe it's not for curative aspect of the topic, recall what Professor Jabez said before. So mainly for prophylactic approach, maybe it's one of the most simpler way in order to give some pressure to the patients without taking care too much about settings and for something that can last hours and hours in a day.
Samuel, comment?
Yes.
1, 2 levels?
No, we have time to discuss. I think that in French, as said by Audrey, it's not our practice to use it, the full face mask, mainly helmet, as you said, as a first-line therapy. This is probably the second or the first-line therapy, as said by Audrey, in a really selected patient who need for a long-term period. This is probably also a cost-effectiveness. As you know, it's very easy. In Italian, we have really no strong data to use it. We have good randomized trial that's showing probably equivalence and no more side effect. We have, as you know, the recent paper from the group of Chicago showing we can obtain probably with a full face mask better results to treat hypoxemic patients. However, in Italy you have the practice, and I asked more than 10 years ago why you use in Italy first-line therapy this. And you know what was the answer is Luciano Gattinani said is good. I don't know if it's true or not, but it's probably a good evidence, clinical, I don't know, because we discussed about the conference consensus. I don't know if the grad, Jean-Michel, will ask this. What
I think it's a major grade. When Luciano says something, the grade is so high.
I share what you said.
I was with Luciano yesterday in Barcelona, and the grade of Luciano is really, really high.
Okay. No, so I think it's probably, in our practice, it's probably the new paradigm for us is try not only to have one single interface for one patient. Probably for one patient for a long period, you can alternate 2 types. One is nasal facial mask, and one could be the full face mask. Why? Because when you alternate, you decrease the strength and the side effect in some select patients. That we try to do it in our practice when it's possible. This is a real practice, not supported by strong data, but I think should be considered in some patients.
Okay, but so we're going to move on. I believe that we should promote the 1 level pressure in France because we not use enough 1 level. It's easy to use, it's probably safe for the patient, so we need to promote this technique in péri-opérative medicine and in ICU.
Yes, and sometimes it could be applied not in intensive care unit, it could be in the intermediate unit. This is a discussion.
This should be discussed in the
absolutely.
guidelines.